You know, I think I did one of these with you maybe 10 years ago, maybe at least 9 years ago, and it wasn't a keynote. So the fact that, 10 years later, we get a keynote on behavioral health, I got to thank everybody in this room for that. So I'm, of course, hopelessly biased about how important that is. So I'll start off with that. So 10 years ago, I would have spent most of this presentation talking about why we should care about behavioral health. We have woken up to that. Most everybody in this room has woken up to that. We know why the brain matters. We know why behavioral health is actually a really important part of overall health. So I'm going to say just a little bit about that in case you need some ammunition with those who are not believers. And then I'll try to say some things about some things that we can do about it. And hopefully finish up with inviting everybody to sort of think about ways in which we can put our heads, our hearts, our minds, and our resources together to really do something about behavioral health. So why should we focus on behavioral health? So I'm going to say, and I don't usually read my slides, but there is a lot of information. So if you need information to convince someone else why this matters, I'm going to just say, brain health and behavioral health are an incredibly important part of all health. And when we're talking about brain health disorder, we're talking about things that most of you either have dealt with in your own lives, in your own families, or you certainly heard about them. We're talking about people who struggle with addictions, with depression, with bipolar disorder, sometimes with autism, sometimes with really serious mental illness like schizophrenia. And these days, you can't open the Seattle Times without reading about something related to behavioral health and brain health. So that's not news to people. These things will affect nearly half of all people living in the state of Washington at some time in their lives. So this is not something that's out there that's rare. This is incredibly common. And maybe the most compelling thing I can say about behavioral health problems is the fact that they cause more health-related disability than any other health problem that we have. So just to be very concrete, brain health problems cause 10, 15 times more disability than things that we care about a lot, such as heart disease, diabetes, cancer, more than 20 times more disability than cancer. So you could say, how the heck could that be? If I got cancer, it could be really terrible and it might even kill me. The big difference is most of us who will deal with cancer at some point in our lives, it'll come at us in our 60s, in our 70s, maybe in our 80s, and then it can be a tough road and you might have to take really difficult treatment and it might even shorten your life by a couple of years. But remember, you've had a good life up to then. The big difference with behavioral health stuff is those of us who deal with behavioral health problems at some point in our lives, 50% of us will have presented by the time we're 14 years old. 75% of us will have presented by the time we're 24 years old. And then if we don't do something about that, you're living with that illness, and it'll cause you disability for the rest of your life. So the cumulative burden that comes from things that affect your brain, from things that affect your health behavior is enormous. And it's not just disability, it's also mortality. So we now have a tremendous interest in the fact that suicide rates are going up, drug overdose rates are going up. We have a person ending their life by suicide every 13 minutes in this country. So while we've been here today talking, every 13 minutes someone ends their life by suicide, and every 8 minutes somebody dies from a drug overdose. Finally, and I put that last because often people mention it first, and I'm going to put it last because I think money is important, but it's not all we're about. Behavioral health conditions are also incredibly expensive. 10 years ago, governments knew this. People were spending a lot of money on police, on jails, on prisons, and we talked about, how that's a problem. Now employers are talking about it in a way I've never heard them talk about it. Now Boeing is coming to me and saying, depression, anxiety, addiction is a bigger drain on our workforce and on our product than anything else we have in healthcare. What are you guys doing about that? That's new. And I think it's really important because people are realizing this isn't just something that affects some people who are homeless, who are on the street. This affects everybody. So I think that's really important. If we take all these little people you see on these slides, let's say these are all the people who live in Seattle or who live in the state of Washington or who live in the US who have a diagnosable behavioral health disorder. So one of these things that I just called out earlier, how many of them will see a psychiatrist? I'm a psychiatrist. I'm a doctor trained to deal with people who have behavioral health problems. How many of them will see a psychiatrist in the next 12 months? Anybody want to call out a number? Somebody said 10%. You looked at the slides. All right, fine. 12%, okay? But now you're going to say there are lots of other people who are doing behavioral health. There are psychologists, there are social workers, there's master's level counselors, there's peers, there is pastoral counselors. How many of them will see somebody who is a professional who's got some sort of formal training? And I'm going to make a very broad definition of this to help somebody with a mental health problem in the next 12 months. 20%, 1 out of 5. Okay? All right. 40% of people will say, sometime in the last year, I had an encounter with a primary care provider who did something about my behavioral health. And this is, for me, this is actually encouraging because 25 years ago when I got into this field, 30 years ago now, when I got into this field, this number was tiny. At this point, especially those folks who are primary care providers in a safety net setting have gotten pretty savvy about the fact that, a lot of what they see in their offices is, medical, some of it is surgical, a lot of it is behavioral health. And so they've actually, made a pretty good effort to do this. But the sad news is 60% of people who live with a diagnosable mental health problem, behavioral health problem, will see no professional help whatsoever in the next year. Now that's interesting. I just told you that these problems cause, maybe 10, 15, 20 times as much disability as cancer. What if I had to say to you that of all the people living in the state of Washington with cancer, 1 out of 10 will see a doctor sometime in the next year who's got training in taking care of a person with cancer? And 1 out of 5 will see somebody who's got any kind of healthcare training, who can help with cancer. We'd find that totally unacceptable, but that is pretty much where we are in behavioral health. So this is a challenge. So access is a huge, huge challenge. 2/3 of primary care providers say, this is my number one challenge. If I need to get help from a specialist for one of my patients, behavioral health is a huge problem. The second bullet on this slide talks about a recent analysis that Milliman did looking at healthcare claims from people who have good commercial health insurance. And what they found is that out-of-network use, so when somebody has to go out of their insurer's network, is about 5, 10, sometimes 15 times greater when you need behavioral health care than when you need medical surgical care. That suggests to me that while we now have really great parity legislation, we haven't really lived it. There is probably some serious issues with network adequacy and parity, even for people who have good commercial insurance. When you look at the numbers, even with good commercial insurance, it can be a month. In child psychiatry, it can be 5, 6 months until you can see a specialist. That's not okay. That's not something we would put up with any other type of healthcare. If you're a person who has a substance use problems, 1 out of 10 will see an addiction specialist sometime in the next 12 months. So huge access problems. If you look at different ways that people look at us, Washington State is an amazing state when it comes to virtually any health indicator. We are, near the top of the heap in virtually all health indicators, not in behavioral health. This is from Mental Health America. They put out an analysis. This is about 2 or 3 years old, but things haven't changed that much. That ranked us near the very bottom in all states in terms of access to mental health care. So this is not something we can be super proud of. There is some good federal statistics on workforce, we have all over the country, but we have especially in rural areas such as Washington State, lots of places where you have little or no access to a mental health professional. So this is data that says that we have in Washington State nearly 160 federal designated mental health workforce shortage areas. Concretely, this analysis says there are 4 million Washingtonians who don't have access to psychiatry. They're estimating we'd need another 200 psychiatrists to meet the bare minimum of what you would say would be an adequate workforce. This is another way to look at this. We have 39 counties in our state, and only about half of them have even just one psychiatrist or psychologist. So we have real challenges, with regards to workforce. Now, what about facilities? Where do we take care of people with mental illness? This is a picture. This is a slide of Western State Hospital. That's a hospital that was built in 1871. It is the place where those with the most serious mental illness still go for their care today. We have almost 1,000 patients who get care there, and a huge portion of the state budget and a huge portion of all the effort that we have, the funded effort that we have in the state goes to this one place to take care of 1,000 people. Now, we're a state that has nearly 1 million people living in it that on any given day have a mental health or substance use problem. So this is an answer that probably didn't even work in 1871, but it's not obviously working terribly well today. And if you believe CMS, or if you believe the Joint Commission, or if you talk to patients who've spent some time there, they would say it's time for something newer, something better. The one other thing I want to say about this, and I'm not saying this to make people who work there feel bad, you're working in a really, really tough environment. What I want to say is we're at the University of Washington. One of our jobs is to find and inspire the next generation of healthcare providers to want to go into behavioral health care because we have such a big shortage, right? And if I show them that they could go work in a facility that was built in 1871 that looks kind of scary, that feels kind of scary, and on some days it is kind of scary, or they could work in a beautiful, shiny new facility here in downtown Seattle called the Seattle Cancer Care Alliance that's nice and shiny and bright, and it looks like, 21st century healthcare. It can be really hard to motivate people to go work in a place like this. So far, I've presented a whole bunch of problems, and now, if you think about it, we don't need one hospital that's going to take up most of our resources. We are evolved from 1871, so I think we recognize now, to do good behavioral health care is more than just one place, one facility, one kind of provider. So I'm not going to narrate this whole slide, but you have it. And I think it's a kind of a useful way to think about what do people who live with behavioral health conditions really need. On the left side is a thing called housing. I just want to echo, I could do a whole session, but we already had a lunch talk on housing, and I agree with almost every single thing that the Lieutenant Governor from Hawaii said. People need a safe place to go at the end of the day. If we don't have that, there's a whole bunch of health care we could throw at people that's probably really missing the mark. So it's incredibly important that we have housing. I do think that we can't forget that, and there isn't a one-size-fits-all answer to that. On the right side is behavioral health care. And behavioral health care, most of it should not happen in hospitals. Most of it should happen in your home, in your community. And there's a whole range of well evidence-based interventions, approaches that we could use, that we could bring to bear. And if we had a healthcare system that looked more like what's on the right side of this slide, then we could be competing with the kind of folks who are doing really good quality care for cancer, for diabetes, for other things. We are so underinvested in workforce, in facilities, in the kinds of ways we take care of people with behavioral health problems. We're probably a decade off from catching up to where the rest of healthcare is, but we have to go there. All right, so how do we close this gap? I'm going to say a couple things about that. So the first thing we can do is we do need to invest in some better facilities, and I'll say a bit more about that later. And I think the state is making some pretty serious, earnest moves in that direction, and I think that's great. The most important thing, I think, we need to invest in people. We need to train people, we have to recruit people, we have to retain people who are making a commitment to working with this really difficult to help population. This is hard work to do, and we have huge dropout rates, not so much for the doctors and the psychologists, but for many of the other behavioral health providers that are working in this field. This is tough work, and you have a huge rate of burnout. It's a little bit like our teachers, we teach them, we train them, they teach for 10 years, and they're like, I can't do this anymore. They're burning out. They're not paid all that much. They're doing really, really difficult work. It's not all that different. And then finally, I think we have to think about, we can't do the stuff we were doing in 1871. We have to do something different. We have to be smarter. How do we use technology in our work? How do we leverage the people we have so we can help more than 1,000 people who are locked up in a state hospital? So I think those are the kind of approaches that I'll say. I'm going to say a little bit about technology. We are living in a tech city here. I just walked over here past a whole bunch of big fancy buildings that are using technology to get stuff to your door. So if Amazon can get you a package, they could certainly get you behavioral health services. So I think we need to be smart to think about, how do we use information technology? How do we use stuff that we can get into your home or wherever you are in a much smarter way than a very traditional approach where you have to take time off from work, get into a car, drive to a facility, sit there and wait, and then have an interaction with somebody. So there's probably lots and lots of opportunities for us to think about using technology that would be good for families, that would be good for patients, and that would also make the lives of providers interesting. This is just one example. This is from one of our investigators, Dror Ben-Zeev. He's developed a smartphone app called Focus. And the interesting thing is this is a tool that is used to help people with schizophrenia, people who have really serious, persistent mental illness, who might be psychotic, hallucinating on any given day. And he did a really nice study that showed that giving them a tool like this on a smartphone allows them to stay in touch with their healthcare team. That actually works as well or better than a whole bunch of really good traditional outpatient mental health care. And we're now actually doing a big project to try to test this in a whole bunch of settings around the state. The other concept that I want to mention is the notion of collaborative care. So this was a pretty radical idea 15, 20 years ago when we first tested it, but it's now gotten a fair amount of recognition, and that is just the fact that, I showed you that 40% of people actually will get mental health services in primary care. So we looked at that and we said, that's not a bad thing, because back then, my colleagues in psychiatry, when I started working in primary care, they would say, what are you doing? You're teaching these primary care doctors to eat our lunch. That's what we do. We're psychiatrists, we're psychologists, and I would say, you have no idea how much lunch there is. I wish we could teach them how to eat your lunch. But these guys are already helping a lot of patients that we never see. What is it that we can do to help them do a better job? And so the concept is basically you take some primary care team and you enhance it. You teach somebody in the practice how to do a good assessment, how to do good brief behavioral interventions, how to measure if things are working, and if things are not working, if things are not improving, that's when you bring your psychiatrist to bear. You bring that psychiatrist in to consult with that primary care team on the patients that are not improving. And if you do that in a systematic way, you can help and reach a lot more patients. We have this concept now implemented in every single one of our 20-plus neighborhood clinics that are part of our UW-Medicine healthcare system. And our psychiatrists who are working in this, and we have a couple of them here today, what they're saying to me is, this is really neat, because I used to help a handful of patients who came to see me in clinic, and if I work in this collaborative care model, I'm helping a lot of patients because I'm helping a primary care provider who has a big panel of patients, and I'm consulting to them on the patients that they're really struggling with, and they can do a lot of the rest of the work. And the longer I do this, the smarter this primary care provider gets. And after about 8 or 10 years, these guys are really savvy, and they're doing a lot of really good behavioral health care. And now they're calling me for the really difficult patients, and that's exactly how it should be. That's a wonderful way to leverage, what a specialist can do. Okay, there's a couple of core principles that we've learned along the way, and if you go on the AIM Center website, you can see them and see them explained a little bit more. The first one is, when we are working together, we really have to collaborate. We can't silo the care. We can't say somebody does your this and somebody does your that. The behavioral health and the primary care really need to be working together, and the patient needs to be feeling like these people are working together, they're talking to each other. The second one is we have to do this for a whole population. So one of the biggest problems we have in this field is people drop out, they fall through the cracks, and if they don't come back to clinic, they're out of sight, out of mind, especially in a busy primary care clinic. So what you have to do is you have to set up a system where you systematically reach out to them. If they don't come back to clinic, you're going after them. That makes a huge difference. We have to do things that work. We now are not in 1871 anymore. We have actually a whole bunch of super effective treatments for people. We have drug treatments that work. We have psychotherapy treatments that work, talk therapies. We have psychosocial interventions that can be incredibly helpful. And if somebody's not getting better, we can't just say, oh, well, I guess they won't get better. That's when we need to make a change. So we need to bring all of the effective treatments that are available today in a systematic way to bear. And when we do that, we can really get people better, and we can get a lot more people better. The finances of this are kind of cool, too. This is an article from the Wall Street Journal, 2013. They wrote an article that basically said that when you do this, when you do good collaborative care and primary care, for every dollar you spend on this, you're saving $6.50 in reduced healthcare costs over the next 4 years. That's an ROI of $6.50 return for every dollar we're spending. That's about as good an ROI as anything I've ever seen in healthcare. We do a lot of this work here at UW. We've proven the concept, but others do this now. This is an article from the Mayo Clinic. They looked at 7,000 of their patients, and they looked to see when they implemented collaborative care in their primary care clinics. They looked at patients before and they looked at patients after they put this in place. And what they published is that before they were doing collaborative care, it took them 600 days for the average person with depression to have a serious improvement. And after they implemented collaborative care, that was down to 86 days. That's a huge difference in the lives of people. This is a study we did here in Seattle. This is a study done in high-risk moms who are depressed. And what we have here is a survival analysis where we look at the number of weeks that go by until somebody's really improved from their depression. The blue line is mostly before we really implemented good collaborative care. And what you see is it took almost a year for about 50% of the moms with depression to have a significant improvement. After improving this program and doing really good collaborative care, what we can see is we shortened this to a couple of weeks, maybe 10, 14 weeks. That's a huge difference. If you're a mother who's just had a baby, if you have serious depression, are you going to be depressed for a year, or is this depression going to get better, in 8, 10 weeks? That makes a huge difference in people's lives. If you'd like to learn a little bit more about collaborative care, the AIMS Center has a great website that I would recommend to you. Some of our colleagues have written a really great book on how to do this work in primary care. And we've been fortunate to get some funding from the state of Washington over the last couple years to train others in how to do primary care. This is the Integrated Care Training Program. Anna Ratzlaff, who directs our residency program, is in charge of this program. And this is some really cool slides that I'm going to show you here. When we started in 2015, we had trained providers in 2 counties how to do good integrated care. And by March 2018, we had trained a provider in virtually every county in the state of Washington on how to do good integrated care. We also started a program called ECHO, or PAC. This is a program that meets every week that primary care providers and others who provide mental health services can log into. It's a televideo learning kind of exercise where you call in, and the first half of the meeting is a presentation on a common behavioral health problem, and the second half is actually discussing cases that people have that they're bringing that are challenging to them. And it's a wonderful way to engage people and to really share knowledge. We have done over 165 of these PAC sessions with 4,500 attendants for over 500 individual patients. So that's thousands of training hours that we could use a piece of technology for that really reaches the entire state. My last couple of slides, I'm going to mention a couple of really neat things that are recent. Many of you know this. So Right before the last legislative session, Governor Inslees stepped out and went out and said we need to do something big on mental health. We need to move beyond 1871 and made a really bold proposal for the state to spend a lot of money on really upgrading our mental health capacities. There's a lot of components to this. There's a big bill on it. There's a big price tag on it. The governor's proposal called for spending $600 million on improving behavioral health care. And there's 3 components that I'll talk about. One of them has to do with better facility. One of them has to do with training more providers. And this is a piece that we're pretty engaged with at the University of Washington. And the last one has to do with how do we help all those providers who are not mental health specialists, but they still need to help people who have mental health problems. So I'll say a little bit about each of those. There was a wonderful bill that in the last legislative period, Frank Chopp and others brought. This is actually, as far as I know, the only bill that then Speaker Chopp ever brought himself. And it called for a substantial amount of funding to build an alternative to Western State Hospital that we're in the planning phase now, called the University of Washington Behavioral Health Teaching Hospital. Actually, earlier this day, I took a couple hours to interview architectural firms for this, and it's really interesting when you have smart people sitting around a table to say, what would a place look like that's not 1871, that's 2023? And it's the kind of place where if you had a behavioral health crisis, you'd want to go there and you'd want to heal and you'd want to go through recovery. What would it look like? And it's really amazing to think about that it took us so long. There is no opportunity that I've seen other than this to put some really smart people in a room and say, let's build something that's really going to be great for the people we serve, but also great for the trainees that we have. Because if we show them a 2023 facility and it's a nice place and it's just as nice as what you would get if you went to cancer treatment somewhere here in town, people will be feeling like this is a good place to work. I see patients getting better here. This is what I need to do, and I need to tell other people about it. So I'm super excited about this. The last thing I'll mention is one of the things in this bill is we said we can't wait till 2023 to have a new hospital. That's when it's slated to open. We need to do something today. So the one thing that we committed to that we could today is we said we can set up, we have a lot of psychiatrists in our department at the University of Washington, and I said many counties don't have a single psychiatrist. We're going to set up a program where any prescribing provider anywhere in the state of Washington that's either in primary care or in a community hospital or in a jail, in a county jail, who is dealing with somebody who has a mental illness can call us and get a consultation on what to do with a patient. We started this in July 2019, right when the legislature funded this. It's up and running. I would say we've gotten calls from all over the state, and it's open right now Monday through Friday from 8 to 5. You can talk to a psychiatrist or a psychologist. And starting next July, it'll be operating 24/7. So if somebody walks into a community hospital emergency department in the middle of the night with psychosis and withdrawals, we'll be happy to talk to you. So what I need from you all is, we're putting a substantial amount of effort and resources behind this. Please help us get the word out about this. Really, really important. Share this. There's a couple hundred people in this room. As each of you shares this with a couple people in your environment, we really want to make good use of these resources. This is another slide, and you have these slides, and I'm happy to share brochures about it. This is how to reach us. We have a few other things that are along these lines. This is something that's been operating for 10 years. We have something called the Partnership Access Line. This is for child psychiatry. So Monday through Friday, 8 to 5, you can call up and say, I'm taking care of a child with a behavioral health problem. Can I talk to a child psychiatrist? And we'll give you a good consultation on that. We have a similar service that we offer providers that are taking care of women during or after pregnancy. This is called PAL for Moms. And because my feeling is The best we can do in mental health is not wait until you're 25 years old and really sick. We need to be taking care of you, ideally, before you're even born. The single best thing we could do is take care of a pregnant woman who's struggling with a mental health or addiction problem, because when we help a person like that, the chances that there is mental illness in a child down the road is actually significantly reduced, and we're happy to. We have 8 perinatal mental health specialists at UW, and they're happy to talk to midwives, to OBs, to family doctors, or other mental health professionals who are taking care of a woman who's got a mental health or addiction problem. Just to summarize, so there's a couple of things we're doing to try to help. There's a lot of detail on this slide, and I'm not going to narrate all of it, but basically, what we tried to do is we tried to say, where is it that we could provide you really good care if you were in a crisis today? So if you're here in Seattle, we operate an emergency department at Harborview that's staffed 24/7 with psychiatry. It's a super busy place, and one of my goals for that program is to say, not only do we want to take care of people who come to Harborview, within a year, we want to make available that capacity to any emergency department in the state 24/7. There isn't going to be a psychiatrist in most of those places, but if you can call up and say, we have a person who walked in here who is psychotic, they're struggling, help me, we can either give you a provider-to-provider consultation, or we could maybe even see the patient using televideo. We have lots of technology tools now that we didn't used to have. We're going to build a new hospital. I talked a little bit about that. I'm super excited about that. We're also building a behavioral health institute at Harborview, which will try to do work and research on new ways to help people, and we have been super fortunate. We've had a huge gift at the University of Washington in the last year to build a new institute for brain health solutions. So the goal for that is to say 10 years from now, not only do we need a new hospital, we need new treatments. There are still a lot of patients that, even with all the treatments we have, they're not all that much better. So we're making a huge investment in improving treatments as well. So I'm going to stop here. Thank you for your time. Thank you so much for giving this much attention to behavioral health. If I have one ask for you, like I said, help me get out the word about our psychiatry consultation line. We want this to be a resource that gets used, a month in, we were already getting calls from all over the state, but I'd love to hear from more people. Thank you.
Are you seeing variation in this model across urban and rural geographies because just of the reality of the rural setting and fewer providers? Is it actually more efficacious in rural settings because people need to be more creative as providers, or is it less so because of the dearth of providers in general?
Yeah, so we're an interesting state. We have very urban, we have very rural, and we have some frontier. And I would say it could be both. So in some of the rural settings, providers are used to having to do a lot of stuff on their own, and they've come up with some pretty creative ways to manage patients that you might not see in an urban primary care clinic. Yeah. But having said that, if they do need help, there isn't a specialist, several counties away. So I think collaborative care, especially if you support it with telehealth technology, can be really, really powerful in a rural setting. But it can also be really helpful in an urban setting. It might look a little bit different. You might staff it a little bit differently. Mm-hmm. In a very rural setting, you might never have a psychiatrist on site. But with televideo technology now, I can put a psychiatrist into every clinic that has internet access in the state of Washington. The interesting thing is, I came to the University of Washington as a fellow in 1994, so 25 years ago. And even in 1994, I had a Tuesday afternoon clinic where I could see patients in a little town called Driggs, Idaho. 2 states and a plane ride away. Wow. And they were getting pretty good psychiatric care. So we had this technology 25 years ago. Yeah. It was a little more clunky than what we have today, but if we're smart and committed, we can put mental health in a lot of places now. So
one of the things that I take from your presentation, which maybe I'm mishearing and maybe this is not the intent, but it's pretty psychiatry heavy, it seems to me. And I know there must be some mid-level baked in there, but I also wonder, obviously you're a psychiatrist, you lead the Department of Psychiatry, so you've got a perspective on this, but It seems like one of the things we've learned as we've become more culturally competent is that community health worker, a community-based worker that may not be licensed in any meaningful way, might be the exact right kind of mental health provider. How do you sort of reconcile what appears to be a needed psychiatric focus with this other thing that we're becoming more savvy about community-level workers?
Yeah, I would say if I had my say, I would make every single person living in the state of Washington, behavioral health competent. The person who needs to know the most about it is the person living with the illness. The person who maybe needs to know the next most about it is, the family, the people are around them. A peer can be incredibly helpful. A peer can do things that a psychiatrist either doesn't know how to do or doesn't get across. Peers are a huge part of our workforce now. At Harborview, for example, we have a fabulous peer bridger program. Family members can do things that they might have not thought they can do. We're never going to have enough psychiatrists, but it's not all that different in other parts of healthcare. If I get cancer care at the Seattle Cancer Care Alliance, I might spend a couple minutes with my oncologist, but I'm going to spend a lot of time with nurses, with physical therapists, with occupational therapists. Behavioral health is no different. It requires a real team, right?
Yeah.
So I want to make sure that I'm not communicating that everybody needs to see a psychiatrist. As you saw, only 1 out of 10 people will see a psychiatrist.
Yeah.
What I'm trying to say is all of the other behavioral health professionals, they'll eventually run into a really challenging situation, and I want to use the psychiatrists and the psychologists we do have, not to see a handful of patients, but I want to leverage them so they can help others who are doing really, really important work in behavioral health.
Yeah. One of the things we have learned on this stage over the years is the importance of not asking people what's wrong with you, but asking them what has happened to you. And that the trauma that people experience over the course of their life, of course, manifests in physical health ways. Compared to 10 years ago when you first spoke at State of Reform, or compared to 25 years ago when you first were a fellow, how have we gotten smarter about trauma-informed care, screening for it or listening for it? Some states are becoming very active on that score, like California. Where are we in Washington?
I think we have a lot of awareness. I think, really just in the last 10 years, people have gotten very savvy about the fact that if you're a person who's had serious trauma, and trauma can be many, many different things, we probably have to be very thoughtful about how we approach a person like this. So trauma-informed care, it's interesting. It's one of those things that we probably all need to be good at, and at a minimum it means being thoughtful about the experiences that a person has had and thinking about what does this mean for how I'm going to interact with them, how I'm going to help them, being thoughtful about listening to them. I think 10, 15 years ago, people either paid no attention to this at all, and a lot of people who had had trauma experiences were getting kind of health care that they just couldn't handle really, or they wouldn't come back. We had a small number of people in psychiatry who we said, they have post-traumatic stress disorder. They were traumatized in the war, so we paid attention to them, but the average person who's had a traumatic life event, we just didn't pay attention to, and that's changed a lot. I think there's almost no more healthcare organization left that doesn't say, how are we thoughtful about the way that we work with in patients who have had traumatic life experiences?
Well, Doctor, thank you for coming and being a capstone on a busy day. Dr. Jürgen Unützer, Chair of the UW Psychiatry Department. Let's give him a round of applause.